everyone, this is Melissa Shigoda from the National Network of Public Health Institutes, and I'm happy to welcome you to the third in our series of Community Health Improvement Capacity Building webinars, the CHIP Collaborative Handbook and Template, with Sarah Hartzig and Jennifer Woodward from the Kansas Health Institute. We'll also be hearing today from Martha Brown and Susan Luguago from Seward County Health Department. We're so glad you could join us today. Before we get to the presentation, I'd like to take a few minutes to provide some background on the series and introduce today's presenters. The purpose of the Community Health Improvement Capacity Building webinar series is to provide an opportunity for NNPHI member institutes to learn from their fellow institutes about how they've selected and adapted specific tools and processes for their community health improvement initiative. This webinar series grew out of the work of the capacity building subgroup of the Community Health Improvement Work Group that started meeting this past fall. For more information on the work group, please contact me via email at mshigoda@nnphi.org, and I'll enter that into the chat box so you all can see how to spell the email address if you want to reach out to me. The first webinar in this series featured Dr. Samantha Francois from Louisiana Public Health Institute, sharing about the rapid regional community health assessment process they used across the four-state Gulf Coast region impacted by the 2010 oil spill. She also shared about how LPHI collaborated with Florida and Mississippi Public Health Institutes to support ongoing community health improvement efforts with their local health departments. Then the second webinar in the series featured Matt Simon and Casey DeCosimo from the North Carolina Institute of Public Health, sharing about how they adapted the Community Assessment for Public Health Emergency Response, CASPER, method for community health assessment data collection. They talked about why they chose this method over other data collection methods, the steps to implement it, and how they developed a handheld app to facilitate the process. The archive webinars of these two presentations are now available on NNPHI's website, along with a written case study for the first webinar. The written case study for the second webinar will be posted very shortly, and we'll send out an announcement about that as soon as we get it up. On today's webinar, Sarah Hartzig and Jennifer Woodward from the Kansas Health Institute will speak about their CHIP Collaborative Handbook and CHIP Template. They'll share how the tools were developed drawing on resources from other public health institutes. We'll also hear about how the tools have been used by a local health department in their community health improvement efforts. Throughout the presentation, we'll stop a few times to ask for questions or comments from participants. At that point, I'll unmute the lines so people can ask their questions themselves, but if we have any problems with feedback or background noise, I'll just leave the lines muted and participants will be able to enter their questions into the chat box, which you should see in the lower left-hand portion of your screen. And we'll also have time at the end for final questions or discussion. So before we get started, I'd like to introduce our presenters. Sarah Hartzig is an analyst at the Kansas Health Institute. She conducts and analyzes research on a variety of projects related to public health and health policy. Sarah is currently serving as a project manager for KHI's Technical Assistance to Health Departments project, which encompasses a variety of efforts in working with health departments to prepare for national accreditation by conducting community health assessments, community health improvement plans, and strategic plans. Sarah also serves as KHI's Health Impact Assessment Team, where her primary role has been data analysis for an HIA on changes to the liquor licensing system in Kansas. Sarah earned her Master's of Science in Global Health at the University of Notre Dame and received her Bachelor's in Science at Kansas State University. Jennifer Woodward, our second presenter, is a senior analyst at Kansas Health Institute. Jennifer brings a clinical perspective with an emphasis on wellness and disease prevention to the Institute's health policy research and coordinates partnerships among public health and healthcare stakeholders to improve the health of Kansas. Before joining KHI, she completed her residency in public health and general preventive medicine at the University of Colorado Health Science Center. Jennifer earned her Doctor of Medicine from the University of Kansas School of Medicine and her Master of Public Health from the University of Texas School of Public Health. Then we'll also hear from Martha Brown, the Administrator of Seward County Health Department. She began her work at Seward County as an RN, then served as Clinical Director, and now is serving as the Health Department's Administrator. She is a member of the Liberal Arts Coalition for Families and on the Parents and Children Together Pact board, and an active member of St. Anthony of Padua Catholic Church. And then we'll hear from Susan Luquago, who is a contracted employee of Seward County Health Department. She's a registered dietitian with bachelor's and master's degrees in nutrition and a PhD in health services research. Along with assisting Seward County with beginning the process of accreditation, she coordinates the Chronic Disease Risk Reduction Grant for Seward County. And she's a co-coordinator for the Healthy Communities Initiative. She's also a member of the Liberal Area Coalition for Families, and is contracted to do public health, nutrition, and work with several other counties in southwest Kansas. So with that, I will turn it over to Sarah to get us started.
All right, thanks, Melissa. This is Sarah Hartzig over at the Kansas Health Institute, and I do want to share with everyone that we are having quite a thunderstorm right now, so my apologies if you hear big crashes of thunder as we're talking through. Hopefully we won't get swept away by any storms or tornadoes here in Kansas. I have to say that because we're in Kansas. Today on the webinar, I want to introduce the Kansas Health Institute, who we are, and the kind of work that we do. Give an overview of the Technical Assistance Project, which is the overarching project for which the CHIP Handbook and Template were developed. And then we'll really dive into the handbook and template, how they were developed, why they were developed, and how to use them. Then we'll hear kind of an on-the-ground story from the Seward County Health Department, who have been really integrated into this work that we've been doing, and then discuss future plans for the project. So the Kansas Health Institute, our mission is to improve the health of all Kansans by supporting effective policymaking, engaging at the state and community levels, and providing nonpartisan, actionable, and evidence-based intervention. We have two primary areas of work here at KHI. There are public health and health policy. We have 4 strategy teams within those, and of course they cross paths quite often. In public health, we primarily work with local health departments, accreditation, and we also have here at KHI the Center for Sharing Public Health Services, so we do a lot of work with multi-jurisdictional public health work. And then with health policy, we work primarily with state legislators here at the state capitol, but also work with local level policymakers as well. We are nonprofit, nonpartisan, and unbiased. We're unaffiliated with academia, and we don't do advocacy. We are here to present evidence-based and unbiased information at the Kansas Health Institute. So I wanted to give you a little bit of the landscape of Kansas in terms of our public health system. We have 105 counties and 100 local health departments. A couple of the health departments have multi-jurisdictional sharing arrangements of multi-counties. We are a decentralized state, so there's a lot of autonomy at the local level, although the locals do work, in many cases, very closely with the state health department. We had our first health department get accredited this year in June, so congratulations to the Johnson County Health Department. We also have 2 other local health departments as well as the State Department of Health in the application process. I wanted to share with you the progress in 2012, which is when our project started, for community health assessment, community health improvement planning. Was really was kind of in the beginning stages. So you can see from this map at the beginning of 2012, the yellow is laying the foundation for community health assessment. The orange is having taken some critical steps. Green is making significant progress, and blue is having completed a community health assessment in the past year. And so across Kansas, there were 3 health departments who had completed their community health assessment. Johnson County, our first accredited health department, is one of them up in the northeast. Then you have Sedgwick, which is where Wichita is, one of our other major urban areas. And then way up in the northwest, Cheyenne County, who are pretty good innovators up there, even though it's a small area. Then moving forward to 2013, you can see that a lot of progress was made in community health assessment, much more blue on the map, as well as green and orange. But you can see there are still a few who were working on their community health assessments. So that kind of sets the stage for when our project started. This project was a 3-year grant from the Kansas Health Foundation from 2012, and it goes through 2015. It's focused on the prerequisites for accreditation, the CHA, the CHIP, and the strategic plan, as well as quality improvement within those. The activities for the project are a mix of face-to-face peer learning, mini grants, and individualized technical assistance. We've got a bunch of state-level partners on the project with us: the Kansas Association of Local Health Departments, the Kansas Department of Health and Environment, and the University of Kansas Area Health Education Center. So we're all working together to make this project happen. There's a little bit more detail about the project activities. So our in-person learning sessions we have held, the first ones on the CHA were held in fall 2012. Then we had some in spring 2013 and just very recently in summer 2014. We held CHIP sessions in spring 2014 and summer 2014, and we have strategic planning sessions upcoming in fall 2014. At those in-person learning sessions, we've really had a mix of hospitals, health departments. We even had a county commissioner come and stay for all of one of the community health improvement planning learning sessions, and so a really good mix of health departments as well as their partners and stakeholders. We also had an individual from Fort Riley who is over near Manhattan, Kansas. It's a military base, and they're looking at exploring accreditation for military operations, which is pretty interesting in terms of military public health. So that's our in-person learning sessions. We've also got the mini grants. We've given 11 mini grants to date. Those are on average $5,000 per application. We put out an RFP early this year with a rolling application, and those mini grants are to cover fees for direct costs, so community health assessment surveys, printing, meetings, as well as consultants to help folks along in the process. And these are really designed to help communities move through several steps of the community health assessment and improvement planning process. Then we also have technical assistance, that individualized TA, which is focused on single steps of the process. It's really there, it exists to remove barriers for folks who are working through and just need a little bit of help to move forward. The funding is covered by the project, and then the recipients must demonstrate that they're really ready for the steps that they've requested. For both the mini grants and for the technical assistance, we have called upon our technical assistance network of experts, which is a pool of primarily local consultants who worked in public health, specifically in community health assessment, improvement planning, and strategic planning. But we've also got a lot of great participation from academia, our nursing department, and public health folks as well. So the CHIP Collaborative Handbook was developed for the in-person session for the Community Health Improvement Planning peer learning session. And that CHIP Collaborative Handbook was really developed as a material tool to have on that in-person session, but also as a standalone document. And then the Community Health Improvement Planning Template was another meeting material that we provided and developed for those meetings. So they were developed in early 2014. We really wanted something that could serve us as meeting materials during the CHIP learning session that we could work on through those meetings with the people who were in attendance to really guide them along what the process was for the Community Health Improvement Plan. We needed that one-stop shop document that had both guidance as well as activities for the day of. But we also wanted it to be a standalone document that could be used for folks who weren't able to attend the in-person sessions. And so when we set out to develop this, we reviewed a whole bunch of tools, templates, exercises, community health improvement plans from around the country, and we're looking for, what the best method of helping people understand the process and practice the process would be. So we developed a handbook that was loosely based on the Michigan Public Health Institute's document, with linkages to other documents that we found helpful. And the Michigan Public Health Institute was really kind of it was a handbook sort of a thing that had both guidance and activities in it. And so that's why we really gravitated towards it. We added some of our own information that we thought would be helpful for our communities who are participating in the sessions, as well as a few additional activities and kind of template type stuff. And so then when we were starting to put in template things into the handbook, we said, what would be great is if we had a template that people could kind of take based on what they learned in the sessions and through the handbook and fill out to kind of be a starting place for their CHIP. And so we developed this template loosely based on one that we found from Connecticut and linked it very closely to the handbook. So it's really meant to be used in conjunction with the handbook, but can also stand alone. And as Jennifer will talk about in just a bit, that template is really meant to be flexible for communities to take and kind of modify as they see fit. So here is the handbook table of contents. And we've broken the CHIP into 9 steps. We had a little background section, and then starting with priorities, goals, objectives and outcome measures, et cetera, and then as you can see, the CHIP development worksheets are included at the end. So here's an example of one of the pages, the Community Health Improvement Plan background. This really just kind of describes what the CHIP is and gives context to the FAB prerequisites of the CHA, the CHIP, and the strategic plan. Of course, the CHA and the CHIP are community-based documents with the health department and community stakeholders, as well as hospitals, other community groups, etc. And then in an ideal world, each would go on and conduct their own strategic plan, of course, with that being a requirement for health departments who are pursuing accreditation. And as you can see, this handbook is very health department focused, but really emphasizes throughout the opportunities for collaboration with hospitals and other partners. This is the organizational structure that we've set up in our CHIP. We recommend that folks select 2 to 6 priority areas. Within each priority area, they would set 1 or more goals. Under each goal, they would set 1 or more objectives, plus the corresponding outcome measures and measures of success. Then evidence-based intervention strategies and action steps. So really working from abstract ideas to the very specific actionable items. This is an example of one of the pages that outlines a step of the CHA. This one is on step 3, set objectives and outcome measures, and it focuses on SMART objectives and a mix of short, medium, and long-term measures. As you can see, it looks very lovely. Our communication staff helped us out a lot in formatting it and really making it eye-catching and easy to grasp what the main points are. So you can see a nice little graphic for the SMART objectives. Then below, that yellow arrow points to a call-out box that directs folks to the framework grid, which is one of the worksheets. It's worksheet number 4, listed in pages 28 and 29. And that worksheet corresponds to the steps. So in the in-person sessions, we use this worksheet as meeting materials. And so we talked a little bit about what writing objectives and outcome measures would look like, and then we broke out into groups and actually practiced writing them. So someone using this on their own would use this as hands-on practice for what they've just read. And here is a screenshot of what that worksheet 4 looks like. So you can see there's a place for them to type in their priority area, goal number, objective, evidence-based intervention strategy, and then the corresponding outcome measures. And we've also provided an example for folks to work through as they're thinking about their own priorities, goals, and objectives in putting together their CHIP. This is another screenshot. This one is on composing an action plan with action steps. And we broke out the goals, objectives, and intervention strategies from the action steps for a few reasons. The action steps detail, which I'll show you in just a second. This is the framework that we're using. The action steps detail was one that we really wanted space for them to be able to write in each of the action steps, responsibilities, target dates, resources, and then progress notes for their process measures. And we really emphasized that in putting together their CHIP, this action steps detail could be something that they could either put in their public CHIP document or keep as internal documentation and communication to their internal CHIP team. And so we kind of left that up to folks as to what level of specificity they wanted to include in a public document, whereas the goals, objectives, intervention strategies, those are all things that make sense to be public. So you can see we kind of talk through all of the bits of writing action steps and how to do so, and then again direct them to the action steps detail template, which was worksheet 8 in the handbook. We also provided an example and tried to be consistent with the example that we included for the goals, objectives, and intervention strategies. So at this point, I am going to hand it over to Jennifer Woodward, and while we're doing that, I'm going to open it up for questions that anybody might have at this point.
The conference has been unmuted.
Hi, this is Samantha Francois from Louisiana Public Health Institute. I had a quick question about who typically attended these learning sessions, so like who from the health departments or other agencies were in attendance.
That's a great question. So primarily we had small health departments in attendance, not exclusively, but primarily. And from those small health departments, it was typically the administrator who had attended those sessions. We also had a good number of staff nurses who were in attendance. From the larger health departments, they had accreditation coordinators come and attend those sessions. So for those who were large enough to have that position, that's who came to the sessions. Does that answer your question?
It sure does. Thank you.
Any other questions? All right. Well, I'll go ahead and hand it over to Jennifer. All right. Thanks, Sarah. So I will be walking through.
The conference has been muted.
And give you an overview about how to use it and how our participants have used it. So as Sarah mentioned, the most important part of the template is that it's just a starting point. It contains the elements that are required in a CHIP document, and it follows the guidance that's outlined in the workbook that Sarah just went through, but it's meant to be individualized and altered to fit the needs of each health department. It's also important to emphasize that it was adapted from that excellent resource developed by the Connecticut Department of Public Health in 2009. And we've listed the reference to that resource on the first page of the template itself. So the template might work best if it's used in conjunction with the handbook that Sarah outlined, but as she mentioned, it's also a standalone tool that a CHIP team could download and use to get started on the document just by itself. So on the slide is the first page of the CHIP template. It is provided to our training participants in a Microsoft Word document so that they can just open it up and modify the contents to suit their needs. There's a spot for the title and subtitle and then an example table of contents. And you can see that we've included modifiable pages for credits and acknowledgments, an executive summary, background information, priority areas, and many other elements. And so we'll take a closer look at a few of these sections in the next couple of slides. This is the section that guides the CHIP team in writing the background information section of the CHIP. It outlines the major points that they need to hit, describing the community that the CHIP applies to, including basic geography, demographics, socioeconomic factors, and vulnerable populations. It also provides an outline on describing the process the health department used to develop the CHIP documents and includes a section for a community profile or a brief presentation of some of the major themes from their CHA, including the community strengths and challenges. Part 2 of the template begins to outline the priority areas that the CHIP team has chosen to focus on for the CHIP. The first section is just a simple list of the priority areas that will be addressed and includes a reminder to include a social determinant of health and health inequities for those health departments who are planning to apply for accreditation. The second section on this page explains the process for using the template, basically that each priority will have its own background, its own goals and objectives, and its own action plan. So this is the part of the document that's meant to be cut and pasted for each priority area that they will plan to address. It guides the writer through a definition of the priority area or health issue, why it's important to their community, and a comparison of the CHIP goals to state and national goals. This section follows the guidance in the workbook that Sarah outlined previously and steps through writing goals, objectives, intervention strategies, and outcome measures within each priority area. Again, the writer can cut and paste this section to have it available for each priority area. This is an example of the action plan template that matches what was outlined in the workbook previously. It has instructions at the top on how to use the action plan, and then an actual fillable and modifiable table that includes the action steps, target date, responsible party, resource needs, partners, and progress notes. And finally, we included a section for monitoring and evaluation, and it follows the same format. Instructions on how to use the table at the top, including any necessary definitions, and then a fillable table below. So the big points to remember are that this is meant to be a baseline guide and meant to be altered and changed according to the CHIP team's needs and process. It works best when presented and used with the handbooks that Sarah outlined, but it can also be a standalone document that a CHIP team can use to guide their document. And obviously just filling in the blanks of this document won't result in a document that communication staff would probably approve of, so it will need some jazzing up with colors, pictures, graphic design, but the basic elements are included here. And with that, Sarah and I can take any additional questions you have, and then we'll turn it over to our Seward County Health Department All-Stars, one of our participants in our learning collaboratives, and a very strong health department in Southwest Kansas to tell you more about their process. So any questions you have at this point?
The conference has been unmuted.
All right, it looks like we have a question that was typed in. Lori Call is asking, how did you ensure the handbook and template meets FAB requirements, and did you educate participants on how pieces meet the FAB requirements in your learning sessions? So that is a great question. We, of course, are not claiming that any CHIP that is made based on our template will or will not be FAB compliant. However, we did build in some things that address FAB guidelines in the standards and measures. And so those things such as the monitoring and evaluation, having measurable goals, objectives, and strategies. In the priority setting section, we talk about, and I'm kind of going backwards, so I apologize. In the priority setting section, we talk about how FAB measure, or standards and measures 1.5 require that you include consideration of social determinants of health. And then that linkage to state and national priorities that Jennifer just showed you is a piece of the FAB requirements as well, and that communities should be linking to state and national priorities where possible. We also have the, where Jennifer was showing you with the action steps. The responsible party is another piece of the FAB requirements. And all of these we called out as we were going through it in the in-person training session. So I sort of jumped around, and I apologize for that. But this was something that we thought carefully about as we were developing and made sure to communicate that to the health departments who were participating. One thing that we did try and keep in mind as we were going through is, I mentioned earlier, we have a lot of small health departments who are participating in these in these learning sessions, and not all of them are planning to apply for FAB accreditation. And so we really tried as much as possible to make this primarily community health assessment and improvement planning session that was targeted towards, more effective and better public health, and of course in line with FAB standards, but not with accreditation as the end goal, if that makes sense. Or not with accreditation as the only end goal, perhaps.
Any other questions right now?
All right. Well, we are going to go ahead and turn it over to Martha Brown at the Seward County Health Department to talk about their CHA and CHIP process. So,
The conference has been muted.
Martha Brown, and I am the administrator of our local health department in Liberal, Kansas, in Seward County. Let me first of all say that we're really tickled to have been asked to participate with the Kansas Health Institute in this webinar. We're hardly experienced at it, so bear with us. We're trying. As you can see, we live in a part of Kansas that might bring memories or bring thoughts of the Wizard of Oz. We do have a lot of wind. We have the oil field industry is huge here, and also farming, lots of wheat fields, lots of flat land in our part of the state. Seward County is located in we're the third state, or the third county from the left at the far southwest corner. We're about 7 miles from Oklahoma in one direction and 5 miles in another direction. Not very far from New Mexico or Texas, so we have a lot of influence from other parts of the country in our little part of the world as well. Our county is a small rural county in the southwest corner, as I mentioned. The population of Seward County is about 24,000. Most of this information is based on the latest census information, so I know that some of that has changed, but that's what we're using. We have two townships in Seward County. One is Liberal. It's the larger of the two. That's where our health department is located. And the other is a smaller community about 17 miles east of here. It's called Kismet. It's a very close-knit, small farming community. And then Liberal we have a beef packing plant here, and really that's about our only industry per se. And according to the census information, our population is about 58% Hispanic or Latino, 33.7% white, 7.9% black, and a few others, including Vietnamese. We have Somalian refugees, some from Burma. Thank you. My mind went blank. And we do a lot of things for those refugees here at the health department. Our school district, I mentioned that our the census information is what these slides are based on. Our school information from the Kansas Department of Education's website, the enrollment last year was 76% Latino. So I think we have a few discrepancies about what that population actually is in our community. We have a lot of migrant people in and out, many undocumented citizens. So our numbers are always kind of hard to get a true picture of. Language, other than English, is spoken in about 55% of the homes in Seward County. And I want to point out that we have a poverty level of about 17.4%. The state poverty level is 13.2%. So we have a lot of people that don't make a lot of money in our county as well. Our health department, unfortunately, does not have that lovely sign on the side that you see, but we're hoping it will come one of these days. We do have a sign, but it's not that pretty. Our health department has 20 employees, and we have a lot of the normal public health programs that many of you are familiar with. We have a maternal and infant program, which is our prenatal health care program that we offer to women that cannot get health care in from other sources. We have family planning, of course, our Healthy Start home visitor program. We give immunizations to infants, the elderly, anyone. We do a lot of flu shots and the other things that you would expect us to do. And as I already mentioned, we do refugee screenings. We do the normal epidemiology and disease surveillance piece that we're required to do. We have a huge car seat distribution program at our health department. One of our Healthy Start home visitors was actually awarded the Child Passenger Safety Technician of the Year at our annual Governor's Conference this year. And she is, we tease that she's our car seat police because if you would happen to be in our town and driving around with a child that's not buckled in, don't come by our health department, or you'll have the police after you. We do the WIC program. We have child care licensing, and we're just starting a new teen pregnancy targeted case management program. We're excited about that. Let's see. I think...
No, you go through that. You're going through this one.
Okay. In 2000, I'm on the wrong slide. Give me just a moment. There we go. This process has been, the process of not so much accreditation, but community health assessment, and the whole thing has been in our vocabulary, of course, for many years, but the thoughts of doing it just have made, it's just been daunting, more than we could handle. And like larger health departments, or unlike larger health departments, we do not have accreditation coordinators or staff that's dedicated to those kinds of public health duties. So it falls on the nurses and the administrator and anybody else we can get to work with this. And I think many of you probably know what that's like. Anyway, we started with the help of Susan, who's going to take over next. She and I started meeting in 2012 and began talking about the accreditation process and conducting a community health assessment. Excuse me. Up to that time, I just did not want to even do it. But we talked and we thought, and we talked and thought, and this went on for a long time. And then we finally decided to jump in, and just about that time, the Kansas Health Institute came along and offered these trainings. So because of them, we've made quite a bit of progress in the last 2 years. And I'm going to let, I will ask if you have any questions at this point. You may want to wait till we're finished. But anyway, I'm going to turn it over to Susan now, and she's going to explain how we actually went about performing our community health assessment and our community health improvement plan.
Thank you. Thank you, Martha. And yeah, we'll just keep on going. This is Susan, as Martha introduced. What I wanted to show you first is our work plan that was, as we mentioned, developed by Kansas Health Institute, and that they were kind enough to share with all of us that went through the trainings. As you saw in the presentation done by Sarah and Jennifer, they had 3 different parts of the collaborative, which has the trainings, and then the mini grant, and then the technical assistance. We have participated heavily in the training, and then coming up on the mini grant, and I'm sure they'll assist us further as well. So this is the work plan that we used based on the template that the Institute provided. We'll go a little further into it as we go further into the presentation. Anyway, so moving on to yes. What using the guideline. The steps were defining the community, establishing our assessment team, and so on, as you can see in the second bullet point. Martha mentioned that we started talking about the process of doing the accreditation, starting with the health assessment and then the improvement plan. And what worked out so beautifully is that once Kansas Health Institute came along and we started doing the training with them, we would meet one week and hear the guidelines about how to do a particular activity, and we would come back and we would do that particular activity. So, for example, on the work plan, one of the things we were to do was to put together an assessment team, so we did that. And with this team, we went through the first two sections of the work plan. We had a meeting in April and then another one in June of 2013. Out of the April meeting came the survey that we used to collect the data. We conducted our assessment and so on in terms of collecting the primary data and all. Going back one slide to the survey, just want to show the survey. Yeah, there we go. We wanted to show you was actually what our assessment looked like. We looked at, when we were developing our survey, we looked at we met together with our entire team, and we looked at several different kinds of surveys that other people had put together, surveys that the Health Institute had brought to our attention so we could get different ideas, and then we put together our own 4-page survey that asked the typical questions that are on an assessment: age, gender, all those sorts of different things. And then, as you heard from what Martha said regarding the population in our community, we have a significant proportion of our population that is of Hispanic descent and speaks Spanish, and so we put it together in English and then also in Spanish. So after we put together the survey and translated it into Spanish, the next step was the data collection. Back to the community health assessment slide. Put together the survey, and we did the data collection between July, thank you, Martha, July and October. We put both the English and the Spanish versions on SurveyMonkey and distributed it to our needs assessment team, to members of the health department, distributed it to all kinds of, say it again?
We put it on Facebook as well.
Yes, Martha would have to say we put it on Facebook because yours truly, the speaker, is not on Facebook. But anyway, and we distributed it to the school district, community college, all kinds of people in our community. We also took it to the Little World Fair in Kismet, one of the towns we mentioned, vaccine clinics, really all kinds of places in the community. And these, I don't want to keep going back and forth to the work plan, but all these steps that we're carrying out are actually what are part of the work plan, the steps in the work plan. So we collected the primary data, assembled secondary data using Kansas Health Matters, the BRFSS from Kansas, and places like that, combined that, all that information, analyzed it, and created a community health profile. That was the next step. Again, this is part of the work plan, if you go back and look at the work plan. Out of the combining all of that information and the data profile, the end part of it were 28 emerging needs at the end of the data profile. So the next step was to determine what the priorities were from these 28 emerging needs. Okay. How we did that, how we did that was using the guidelines in our CHIP handbook again. If you think that I'm talking to myself, I'm not. There are other people in this room. But how we did that was using the guidelines in handbook, and what that entailed here in our county was we had a meeting now in 2014. We started last year in 2014 in terms of setting the priorities, and then in April, going from the priorities to the goals and objectives and outcome measures. How we did that, though, is through something that we learned in one of our learning collaboratives, which is a democracy method, which is kind of cool. Some of you already know what this is, but we found it very interesting. I just wanted to explain it a little bit. What we did is we took those 28 emerging needs and put them on a large post-it sheet around the around the room. Each stakeholder was given 5 blue dots and asked to put one on each emerging need that they thought was the most important. At the end of the first round, 10 items had the highest number of dots, and all the other post-it sheets were removed. Then each person was again given 5 green dots and asked to place a dot on each of the emerging needs that they thought was the most important out of the 10 that were remaining, and out of those, 6 emerged as our priorities. The other thing that we had, we asked the bigger team to keep in mind was, there's that one document that's in the handbook. It's about, like, you had to keep in mind, like, was it feasible to address this need? Was it, do you remember that? Was it feasible? And those sorts of things. Anyway, if somebody has a question about that, we can talk about it. But there were some factors to keep in mind.
It was even as if there were a problem that everyone in our community was concerned with.
Mm-hmm.
If we knew as a team that we really could not do anything about it,
right,
we would not choose that.
Keep that in mind.
We would not choose that as one of our 6 issues to address in our community health improvement plan.
Yes, and this is one of the areas that our lovely instructors told us about. So, but we'll find it if we need to. Anyway, and so we selected. We selected priorities. Like I said, those 6 priorities, and then went into identifying the strategies that we would use. We did that in May, and in the process right now of identifying our strengths, resources, assets, and efforts towards these strategies. We are doing this by seeking feedback from, as you mentioned, the larger community assessment team, our commissioners. We've met with the Lunchtime Lions, the school district, patrons of our library, the Liberal Area Coalition for Families, and various other community entities like that. That's what we're doing at this time. We wanted to show you an example of another way that we've used the CHIP template, which is part of what's in the document that we're working on, and that hopefully you will recognize from earlier in this presentation, which is examples of the priority areas that emerged from our work. An example right there is teenage pregnancy, and as you can see, we have an introduction at the top with some background information, some secondary information, some of our primary data, and then the goal, the objectives, the strategies, and then the outcomes. And I think Sarah, I'm not sure if it's Sarah or Jennifer who mentioned, you can have one or more than one or 2. And anyway, so we have six priority areas, and what you have in front of you is the example of 2 of them. Okay?
Okay, this is Martha again. I wanted to mention that when Sarah spoke with us about presenting, part of what we have been doing, she said that a lot of people wanted to know how much it costs and how many people it took to do it, I guess. And so we included a couple of slides, and Susan will talk about them again for a minute, but I will say that it does take money, and it definitely takes time. And once again, just as we were starting to wonder how we would do this, the Kansas Health Institute, we found out that they were offering a mini grant that would help us with some of the expenses of doing this.
And what we were very, very pleased and fortunate to do, we applied, and we were very fortunate to be approved for $3,000. And in front of you there is you can see how we anticipate and have already used the funding that we received. In terms of staff capacity, like Martha mentioned, we have currently a core team of 4 individuals, a larger team of 25 individuals. Martha mentioned when we started, and I cannot emphasize how helpful it was. And the Kansas Health Institute did not ask us to say this at all, but really what a difference it made in terms of timing for us from the very beginning and throughout the process, where we would talk about and get training on one part, and then it would come up that it was going to work so well for us. And actually, we all jumped for joy when we saw that there's going to be some training on strategic planning, because that's going to be coming up next, and we look forward to that as well. It has saved us a great deal of time and really knowing what to do as we move forward. That talks about some of the money that we've spent, but you can read it for yourself. In terms of the lessons we've learned, bottom line, select a core team to work with, because they're the ones that will stay with the process and keep moving it forward. Have a work plan with timelines. You don't even have to develop it from scratch, because the Health Institute has already put it together. Seek assistance from experts. This is a dog. Get feedback from community members and just keep looking forward. That's it. Thank you very much. Back to you, Sarah.
Great. Thank you, Seward. So as you can tell, we have a fabulous example of a community where they've had some great results from participating in this process. And I don't want to say that it's really our doing, because the Seward County folks have been one of the most engaged, enthusiastic, and interactive health departments that we've worked with. So again, thank you guys so much for being willing to share your experience with the folks on this call. So that's one example of a health department that really has taken these efforts that we've been putting out and run with them, and we really appreciate that. Some of the other results of this broader project, we've had 121 people participating in these learning sessions, and that's health departments, hospitals, and the other stakeholders, as I mentioned. And when I went back to add those up, I was actually really surprised. That's a lot of people, so I'm feeling pretty good about that. We've distributed $58,000 in mini grant funds to a variety of health departments, and I'll show you a map of where they are here in just a second. We've also developed some distance learning modules. So the CHIP sessions that the Seward County folks attended were multi-day sessions. We actually condensed the content from both of those into one-day sessions, and then developed some distance learning modules for people to get a brief overview of all of the concepts before the session, so that in person we could do a lot of that interactive work, practice priority setting methods, etc., that folks found really engaging and helpful as they were going through the previous sessions, which we had learned from the evaluations and talking with folks. And so we did that in order to be able to have more people attend those sessions, because a one-day commitment obviously is a little bit less than a 3-day commitment in many cases. We also have done a lot of quality improvement on our end throughout this project. In terms of curriculum design, as I mentioned, we really have streamlined, as we've repeated the content, we've really streamlined what we've included and how we've delivered it. So that's been really, really fun for us. And then in terms of grant writing, many of the communities, not Seward of course, but many of the communities that we've worked with who have applied for those mini grants have had a large learning curve in terms of writing grant deliverables and making timelines, and really targeting their needs to what the grant is requiring. And so especially some of the very, very small health departments that we've worked with has been a lot of learning and a lot of capacity building in terms of grant writing, which really is the goal of this project, to build capacity at the local level for many of these activities that are related to accreditation readiness. So hopefully then in the future, as they're applying for additional grants to implement programs or projects that are part of the CHIP, they'll have a little bit of experience under their belt. As I mentioned, I have some maps to show you. So the folks from the face-to-face sessions come from these counties in blue. The red stars that you can see on the map, the one up in the upper right-hand corner, that's Topeka. That's where we are here at KHI. And then the other red star is Seward County down with Martha and Susan out there. So there's a lot of space between us, but it really has been a lot of fun working with them. And these are the folks that have been awarded mini grants. You can see they're kind of scattered throughout the state. There's a big group of people down here in southeast Kansas. You can see a big cluster. They actually applied as a multi-jurisdictional collaborative in conducting their CHIP. They applied for CHIP activities. And so it'll be really interesting to see how they move along with their mini grant as a group of counties. We also have the Technical Assistance Network of Experts, and I mentioned these guys up front. We primarily have local consultants who've worked in accreditation, readiness, CHA, CHIP, and strategic planning. We also have some health department personnel who are serving as peer assisters, and that's really building capacity on two ends. So building the capacity of the health department personnel who are a little bit more seasoned and experienced, because you see one, do one, and then teach one. They're really learning it more in depth as they assist others. And then, of course, building the capacity on the part of those who are requesting the technical assistance. And then we have academia, which is really a more statewide conversation about how to incorporate collaboration between local health departments and academia. Of course, that's part of the FAB domains, and really hits on one that I think people are trying to find ways to build those bridges. And so having the academia folks as part of our technical assistance network, I think has been really, really good. It's been a learning experience for me, and we're hoping that even past the life of this project, this technical assistance network of experts is going to be able to stay together and to continue beyond our grant. Just based on feedback that we've had at a couple meetings with this network, they really appreciate having a kind of a convening of folks who are really committed to building capacity at the local level, and talking with folks that they don't normally get to sit down around the table with. They know each other and they see each other, but they don't always have chance to have these conversations. So that's something that we really hope will continue past the life of our project. So plans in the project moving forward, we are going to have additional in-person sessions, of course, on the strategic plan. We're offering additional mini grants and technical assistance as we continue on. And I was just talking about the sustainability of the technical assistance network of experts, really hoping to connect it to that conversation of collaboration with academic institutions statewide. We also hope to do a little bit of additional work in quality improvement and kind of domains 9 and 10 of FAB. As I mentioned at the beginning, many of the health departments who have attended our CHA, our CHIP sessions have been smaller health departments who aren't necessarily thinking about accreditation, but as more folks are kind of buying in to the thought of becoming accredited and really working towards that, we're hoping to build some additional capacity specific to domains 9 and 10 in FAB. So that's something that's kind of, it's still in conversations, but something we're working towards. And so anyway, we hope to continue to do this work and to continue to share it with folks, and I will just open it up for any final questions.
The conference has been unmuted.
Hi everyone, this is Melissa Shigoda again. It sounds like we don't have any questions, and we're right at time. So I guess I will just go ahead and wrap us up. The presentation, I'm posting a link right now to the chat box so that you can copy and paste these instead of just retyping them from this slide. The presentation slides with the links to tools from today's webinar can be found on Dropbox. And we also have a Qualtrics survey for you to fill out and let us know how this webinar series has been going and if you have any suggestions for future webinars. And finally, a huge thanks to Sarah, Jennifer, Martha, and Susan for sharing their experience today and all the wonderful tools. And a big thank you to everyone who joined and listened in. Thanks, everyone.
Yes, thanks for joining us. Thank you, Melissa, for hosting.
Yeah, no problem. Thanks. Bye.
something like that, at least I could use for you. Glass of alcohol for the. Or can, conference. No, this was awesome.